here, and we are performing a procedure called an endoscopic laser-assisted facet joint denervation. And we do this by finding the medial branch of the dorsal ramus, which we think is right there. We're looking at 12 o'clock towards the superior facet, and just straight below us will be the transverse process. We're on the right side. There's a little bit of muscle fibers there attached to the facet joint, a little bit of fat. So we're going to come in with our laser. This is a holmium YAG medical laser. Same laser we use for our Duke laser disc repair procedure. And Dr. Patel and I are going to bring the laser in, and we're going to have to basically transect the nerve. And to do that, we have to get down to it. And that's the nerve right there. And by transecting the nerve, we're basically denervating this joint. And denervating the joint means we're taking the pain from the joint away. And the facet joint pain is transmitted along nerves up to the brain. This is a relatively newer procedure. It was, I think, pioneered by Dr. Anthony Young. Dr. Anthony Young is an orthopedic surgeon who is a pioneer in endoscopic surgery. And Dr. Young taught me how to do this procedure. And Dr. Patel and I have been starting to perform these when patients who have a radiofrequency ablation that doesn't work because there's too much scar tissue or too much soft tissue in the area of the RFA. And so we come in with the laser, and you can visualize the nerve and you can transect the nerve. All right. And I'm feeling with the tip of the laser fiber, I'm feeling for the transverse process, which is down there. I need to angle towards the facet a little bit. There's a lot of fat here, and the reason why there's fat around the facet joint is because fat's an energy source for inflammation. So the body brings fat here to basically provide energy for the inflammation or arthritis around the joint. There's the transverse process. And I just want to make sure, there, see the bone right there? That's the bone of the transverse process. I want to make sure I get all the fibers of the nerve. We don't want to leave anything behind. And this is not the nerve root we're getting. This is the branch that comes off of the nerve root that travels to the facet joint and actually brings the pain that people feel from their facet joint to their brain. So we want to stop that transmission of that pain signal. And to stop the transmission of the pain signal, you have to cut the nerve. And you could see the nerve was there. Now this patient actually had a radiofrequency ablation done with a needle, with a probe. It's called a radiofrequency probe. And it was done how long ago, Dr. Patel? 2 weeks ago, okay? And we did it the standard way, where Dr. Patel went in and used the radiofrequency probe and burned the nerve. But you could see the nerve was still there. So some people's nerves are really hard to get to. And when you use a radiofrequency probe, you don't know where the nerve is. You can't see the nerve. But with endoscope, you can actually see it. And we visualized it and we cut it. I'm just making sure we're getting any other small branches that may be coming off the nerve like before we cut it. Because the nerve travels from the right side of the screen at 3 o'clock to the left side. And it runs right in this area where the tip of the laser is. We've cut the nerve, and I want to make sure we don't leave any of the fibers behind that could transmit pain. So I want to make sure we do everything we can to get rid of this patient's pain. Can you see the TP? Do we move a little bit? Where is it? Over here? Yeah. There it is. So one thing, Patel, you never want to do is bring your laser fiber inside the scope, like in here where you can't see it, and then hit the pedal. You'll blast the little lenses right out, the lenses, and then it's like a $4,000 repair. So anyway, do we have any questions from our audience?
No questions yet, doctor.
Sorry it took us a while to get the broadcast going, but I feel we've already done one level, and now we're done with the second. You agree? So on to the last level, laser off. And Dr. Patel and I are doing this procedure together. I do all the endoscopic surgery here, and Dr. Patel does all the rhizotomies here, so this is a combination. An endoscopic, laser-assisted rhizotomy. I can feel the TP. Now, because there's inflammation from the procedure, we'll put a tiny little bit of anti-inflammatory medicine, and we're ready to rock on to our last level. That's the L5-S1 level. Any questions from the audience? What you're watching is a newer technology. It's endoscopic radio frequency ablation, but it's not using radio frequency. We're using a laser instead of radio frequency. Radio frequency creates plasma at the tip of the probe, and plasma is not as good as laser. Laser's better when it comes to this application. The radio frequency probe heats up to 80 degrees Celsius, and you can see that it doesn't, you can't really target the nerve because you can't see the nerve. That's the problem. So all you do is you use the X-ray to place the needle, and then through the needle you put a little probe that's connected to a machine that sends electricity down the probe and heats up the tip, and the tip then creates plasma around the tip, which deadens tissues, but it doesn't work that well. But that's what all interventional pain management doctors do. And that was the best we had until Dr. Young, Anthony Young, I think, developed the first endoscopic rhizotomy procedure, which I learned from him years ago. And we've brought it to Duke Spine Institute, and we're finding that there's a lot of people who get rhizotomy done. They get better for a little while, and then the pain comes back. And so we're able to take those patients now and do this more advanced procedure where we can visualize the actual medial branch of the dorsal ramus, or the dorsal ramus itself in this case at L5-S1, and we're going to cut the dorsal ramus with the laser. That way we know the job is done. We can visually see it. And the results are better because it's longer lasting as well. So not only do we have greater accuracy, but we also have more durable results because the laser really cuts that nerve good rather than the probe, which really doesn't cut it at all. It just burns it. So the nerve can recover from the probe, but it won't recover from the laser procedure. It gives a more permanent relief of pain. This patient had 100% relief of her facet pain for 3 days. On the third day, the pain came back. That was 2 weeks ago when she had the rhizotomy done. So we knew that the facet joints were the cause of the problem, but we also knew that the procedure, the rhizotomy, wasn't a very good one, even though Dr. Patel is probably the best in the country at doing them. So that's when we made the decision to talk about endoscopic laser-assisted denervation of the joint. And that's what we're doing today. She didn't want to wait. She was in pain, so we got her in one day and got it done. She was in the office yesterday for a follow-up after the radio frequency ablation, and she told me, yeah, I did great for 3 days, and then the pain came back. And I said, well, you want to do it tomorrow with the endoscope and the laser? She said, yes. So here she is, less than 24 hours later. That's the kind of care you get at Duke Spine Institute. We get people in right away. We don't make you wait for 6 months to get care. All right. You happy? Let's just check that one more time. Use the coker, Dr. Patel. I don't want you to get your hands in the way. Just hold pressure down with the coker, and that way it won't move. Are you happy with that? That looks really good, huh? So right now we're at the, what is it, the sacroala?
Yeah.
Right where the S1 facet, superior articular facet, and the sacroala meet. And that's where this L5 dorsal ramus is going to be. All right, Dr. Patel. Yep, go out. Why don't you come over here, and I will hold it for you in place. Wait, I got to get my hand in here. All right. You want to make sure that the suction's not on, Patel, because if it is, it'll make bubbles. So I just turn it off for you. All right, don't move the scope too much. Just all right, good. So you know the superior facet is just medial, and if you want to poke around a little bit with that pituitary, you can see there's a lot of fat down there. So we'll probably try to pull some of that fat out. There is some veins there as well. But try to just poke around and feel for the ala underneath the fat. Do you feel bone there? Yeah? Good. All right, so try to grab some of that fat out. A lot of times the nerve is sitting under the fat. Just grab superficially. You don't even have to come out all the way. You can just open it in there and fat will release. Yeah. So you can kind of just do grabbing and release, grab and release. There you go. See how the fat floats up? That may be the nerve. Let's just get a better look. All right, you want to bring your laser in? So we believe that's the nerve there. No, don't twist. You got to just let it come straight out. As soon as you start bowing it, then you will, you'll not be able to get it out. You'll bend it. Remember, don't go on until you can see the tip. Bring your scope back a little bit. There you go. So Dr. Patel, I've trained Dr. Patel on some endoscopic surgery in the past. Ooh, don't move your body. Don't move your body. Wait, no, come back up. And don't go deep with the laser tip. Start superficial. There you go. Yeah, okay. Good. I wouldn't go deep. I'd go superficial first and clear some of that tissue. And then turn it off and feel the bone with the tip. You feel bone? Good. All right, you're doing a great job. Yeah, you can do a little blasting because what that is, it's actually emulsifying the fat. You know, the fat gets emulsified, and then it just creates a whiteout, so to speak. And so it's really good to stay superficial with your laser. Bring your scope up. You don't want to get it too close. The shock wave from the laser will literally disrupt the little lenses. So I would stay superficial. Yep, get that stuff at the top first, so you're not like in a hole. Does that make sense? Yep. You want to clear all the stuff superficially first by rolling your fingers around and moving your scope to move the laser tip. Yeah. Try. There you go. See how it moves the laser? Good. I wouldn't bury it. Don't bury it. You always want to see the tip of your laser so you know where it is. So the key is to clear the soft tissue out. Stop for a second. Grab that. Take your laser out. Laser off. And grab that fat lobule. So there's a lot of fat around these facet joints that are inflamed because, after all, the inflammation is energy-intensive process. Turn it the other way. You got to turn. Yep. No, your opening. See where your opening is. Wherever that is. I think it's the other side. You want to hold on. Turn your hand 180 degrees. There you go. And grab that fat. Yeah, there you go. You still need to take a little more. Turn it more. Turn your hand more. Turn your whole body. Yeah. So it's really a dance with the scope. And try to get that fat piece right there. That one one at like 6 o'clock so we can see better. All right, come on out with the fat. Let Luis wipe it. So this is our last facet we're denervating with the laser. No, don't bend. It's just got to be, you have to let the tube guide you. You can't force it. You got to make your hand go to the ceiling instead of towards you. Does that make sense? Mm-hmm. Otherwise you'll be spending a lot of money repairing instruments. Here, I'll show you. Let me show you. Okay, yeah. A little more. You're going to have to turn your body. Get closer to the patient. There you go. Get closer. Turn it even more. One thing I like to do, I'll show you. Let me show you. Okay? Just turn it like this. You don't even have to put your hand all the way in it and just grab. Make sense? And then come straight up. All right, get back to it with your laser. Laser. So we are at the, that looks like that ligament that goes over the nerve, right? Pull back a little bit. Trying to get you closer to the facet. I would get the white stuff at 12 o'clock. Man, I didn't realize how cold this irrigation is. It's like freezing my hands. You're going to have to bring your scope a little closer so you can see what you're doing. Let me help you with your scope. Okay. There you go. There you go. All right, let me come in for a little bit. I think that's bone down there. You see it? Laser off. Switch with me. No, come around to my back. Good? All right, let's see. Now let's see if we can find that. There we go. That may be, huh? Right? Let's see that. Now watch what I do. I start with the superficial stuff so that I create a window that you can get to the deeper stuff. You know what I mean? Rather than just going deep. You always want to see your tip. You always want to see, where is my tip? Because your tip is the dangerous part. That may be the nerve right there. No, that's just some fat. I think those are branches. Now notice how I'm not actually turning on the laser. I'm just probing. And are we still on the sacroiliac? Let me see the grabber. Laser off. I think we're pointing a little further lower than I want to be. Let's get the fluoro in, just make sure we're in the same place we're supposed to be. Is he there? So Luis, you're going to have to move south. I'll take the scope out for a moment. Try not to move that around. Let's just see where it is. You'll need a coker. We need Jordan. Luis, what are you going to do? Stay north? All right. And turn it. Turn it. There you go. Perfect. See how you can play with it like that? Just watch the front of it. Jordan, yeah, don't go until we're done, okay? Huh?
And do me a favor, turn the scope off. Please, yes.
Will you turn the scope off, somebody? All right, let's go. Let's get this thing in here.
Thank you, buddy. Lights on, please.
Is that where we are now? Or is that the last picture? All right, yeah, we've slid down a little bit. Don't you agree?
Oblique,
Yeah.
change the oblique towards me. Okay, thank you. Keep going. Little bit more. Okay.
So we slid down a little. What do you think? Slid down a little? We need to go a little bit north. You happy with that right there? Maybe point a little more medial or pick up the tip and move it a little more medial till you hit the facet. What do you think about that? That's good? All right. Let's get that fluoro out, get the scope on. All right, you got it in position?
Yeah.
So let's go see. I have no idea what you're saying. Thank you. Yep. Alrighty then. Alright, let me have the laser. So a lot of times when you get a little bit of clot like that, the laser itself will just blast some of the clot away and make things more visible. So you feel we're in a good position? Let me see the grabber. So at 12 o'clock is a superior facet of S1. And Patel, you gonna hold it good? What we want to do is find that nerve and that feels like bone there. Take. So our job is to cut that nerve. And we're going to try to do it with a laser. A lot of soft tissue. This may be why the procedure you did helped but didn't really fix the problem, you know? There's way too much soft tissue here.
Dr. Duke, do you have time for a question?
Yeah, I'll take a question.
All right, we have a comment from
I just
YouTube.
can't get my my laser fiber more north. There we go. Yeah, go ahead and ask the question.
All right, we have a comment on YouTube. We have a patient that has MRI results for their cervical and lumbar in 2020, and they
Yep.
got their thoracic in 2017. They're
Uh-huh.
getting degenerative disc disease symptoms, and they want to know should they get an update on their MRIs.
How old is the MRI?
The thoracic is in 2017, and the lumbar and cervical he got done in the prior year, in 2020.
Yeah, I think you need newer films because 2017 is too old. All right, are you confident of where the tip is? It hasn't moved significantly? So one of our viewers is saying that they've got MRIs that are from 2017 and they want to know if those MRIs are good enough for diagnostic purposes for today. And my answer is no. You need MRIs that are about a year old before you have treatment. I definitely feel the bone there. All right. A lot of fat. We probably have 5 minutes more, doctor. I don't know for sure, but that's what I'm thinking. So I can feel the bone right here. Why is the bone significant? Well, number one, it tells you where you're supposed to be. You're supposed to be just above the bone, which we are. And it also is like there's no way the nerves go through the bone. So as long as you get the soft tissue above the bone, you should be doing a good job. And you should have that nerve treated properly, because that nerve is going to be in the soft tissues above the bone. I feel like we moved again. Let's get another x-ray. Scope off. Here, let me feel that. Actually, go ahead and get it positioned where you want it. So you see how much soft tissue there is around the area where the rhizotomy is done, and all that soft tissue does is it sucks away the current from the tip of the probe. Take the fluid adapter off, Luis. I want to see without the fluid adapter. All right, go ahead. Pubic symphysis looks good. All right, again, we've gone a little lateral. I think we want to move a little bit more medial towards that facet joint. I mean, the nerve is going to run where, Patel? Right there, right? Can you bump the tip of that against? I would take the coker out. Just use your hands. Feel the facet joint medially, and when you hit it, then get an X-ray and confirm it. What do you think? That looks good. Yeah. Right? All right. So let me feel it. Coker. Shot. To north. Shot. Looks good or no? You happy with that?
A little, I mean, we can with the tube, we can see, right? Maybe a little lateral.
Shot?
It must be there.
You think I'm too lateral? Too north?
Too north.
How about here? So you can see even with the fluoro machine, shot?
A little medial.
A little more medial? I'm bumping up against the joint. That's what I think. I'm bumping up against the joint. So I think that's good right there. Take that. I got it. Fluoro out. Scope on. Where's my scope view? Yeah, right there. All right. Now, put the laser in. I'm going to need someone to hold this tube right here. You got to support it on the butt.
Yeah.
You got to put your hand on the butt. You can see the angle. Let's preserve that angle. Remember, I'm going to be working against you with the endoscope. Grab her. Because this endoscope can move you quite easily because I have mechanical advantage on you. So you got to keep us centered right here. I feel bone right there. That feels really good. I feel like we're in the right spot. Just need to get in there and zap that stuff, zap that tissue away. Was that the only question we've had so far?
They got a follow-up saying that they got their cervical and lumbar MRIs in December of 2020. Doctor?
December of 2020 is fine.
Okay.
Yeah. That looks like right there. That could be some nerve fibers. But so far, so good. I'm almost on the bone. Just a few more minutes, doctor. That's bone right there. You see it? That right there. So this is all lateral capsule and soft tissue around the joint. I would love to see just a thick trunk, you know. So let's let it rock, but keep it going south. Yeah. Good. That's all the lateral part of the S1 joint on the right side. That's what we want to see. Right there. You can see the bone right here. That's the sacroala. And there's the nerve probably right there. You see it? Right there. That was the nerve right there. See it? See the nerve, guys? It looks like a little round thing right there, like a spaghetti. That is the branch of the nerve, I think. It was running right in the groove here.
That's where it's around.
Huh?
That's where it wraps around.
Yeah, that's where it wraps around. Pretty cool. So we found it, we cut it. I just want to make sure that we get everything in case there's two branches. Those are nerves right there. You can see them right there that I'm blasting. They're just little fine fibers going up to the joint. They were probably coming from that dorsal ramus of 5 that we just cut, transected.
Dr.
All right,
Duke?
that looks pretty good. I don't think there's any nerve in there. I think we're done. Laser off, scope off, all done. Was there another question? Go ahead. Thank you, Dr. Patel.
Yes, doctor. Was the patient awake at any part of the surgery?
No, the patient's not awake in the surgery. They're asleep for the whole thing. Unlike the laser surgery on the disc, the Duke laser disc repair, we're not operating in the foramen where the nerve root is, so we don't need the patient to be awake. We're staying behind the foramen, staying away from the nerve root, so there's no risk to the nerve root unless you just get lost. And that's why we keep checking the fluoro to make sure we're not somewhere we're not supposed to be. The neuroforamen is literally just north of where we're working. I would say no complication. EBL 1 mil. And this was Dr. Duke, I'm assistant surgeon, Dr. Patel, perfect.
I don't have like a super bill for this officially.
Yeah.
So I talked to Sheena. I think
We need one.
create one.
Yeah.
Yeah.
All right, let's type up your questions. I'll be in the conference room momentarily. And we've got one more surgery today, the L4-5, L5-S1 Duke laser disc repair. That's a different type of procedure. No, I don't think so. It's up to you guys. Movement by not fusing, and we don't put anything in your body and leave anything in there. It's all natural. Are you glad you did it?
100% glad I did it.
Yeah.
I tell the story all the time. Everyone goes, "Oh my goodness, you had back surgery. Are you okay? I can't believe, how are you walking around and you look so comfortable?" And I tell them, I don't have anything in me. And I tell them how the surgery went, and I don't mind showing them the video, and they're blown away. And so I often share your website and number with many people.
Thank you. Dr. Dumajian here with one of my patients who actually happens to be a musician and is here in the local high school, right? A very large high school for that matter.
Yep, absolutely. The largest in the district.
Hello, everyone. My name is Diego. I run the video programming here at Duke Spine Institute. Dr. Duke is on his way. Please type up your questions. He will be more than welcome to answer any of your questions. Meanwhile, please enjoy this video of one of our patient testimonies. Thank you.
I was out, on a very long run, 15K, and I noticed a pain running down my leg. I thought it was due to poor stretching and not enough stretching, so I increased that. It wasn't going away, which was a red flag indicator, and I saw my doctor, who then recommended an MRI to see what was going on, and it showed the herniated discs, the L4, L5, L5-S1, who then recommended me to go to another center to receive back surgery. To which, and I had told you before, my wife saved the day and found you guys.
They usually do. The wives usually do. They keep us out of trouble.
Yes, she often does. So, when I came to see you with that same problem, with the pain shooting down my leg, I would say at days, 9 out of 10, I would have to call off of work, sit at home, or lay at home, honestly, just to stay off of it because the pain was so great.
Yeah.
Yeah.
So it really had, the pain in your back and down your leg had a really bad effect on the quality of your life and your ability to do your job. And what did the other center, by the way, what did they recommend in terms of treatment for you?
A fusion.
A fusion, right?
Yes.
So you didn't want a fusion.
Absolutely
You didn't want
not.
a fusion. You didn't want to lose the natural movement from your lower back. And you found out, your wife found out about our laser surgery, which preserves movement by not fusing. And we don't put anything in your body and leave anything in there. So your back pain that you had before surgery, which was done 6 weeks ago, by the way, how much of that pain do you still have?
Zero.
Gone.
Zero.
Cured.
Yes.
Awesome. And the leg pain?
It is gone. Yeah, the pain shooting down my leg has completely gone away, and it is wonderful to be able to climb the bleachers in the stadium, to get on my podium, and to be able to play my saxophone comfortably.
Awesome. Well, congratulations. You had the courage to do the surgery and have the laser surgery repair your disc, and here you are 6 weeks later doing fantastic. Please tell your wife, give her my best regards. Okay?
Thank you so much.
All right.
Thank you all for being very patient. Dr. Duke is still making his way over to our broadcast station. Please enjoy another patient testimony.
Let's get started. I'm Dr. Duke Majin. We're here with one of our patients who traveled to here from Texas, correct?
No, Auburn, Alabama.
Sorry, Alabama. All right, so Alabama. And why did you come to Duke Spine Institute?
Because the last flare-up of L4 that ruptured in 1999 was unbearable, and my wife can be a testament to that. Who took care of me for 10 days, crying on the floor, with an amazing, incredible pain.
Okay. And you've had that pain now in your lower back for 22 years.
Yes.
You've tried physical therapy and exercises, stretching, but none of those things worked.
No, temporarily.
Yeah. And where was your pain coming from? Do you know?
It was around the belt region in the back. Yeah.
So the L4-5 and L5-S1 discs had tears and they had inflammation and pain. He also had sacroiliac joint inflammation and pain. And Dr. Patel standing here, which we don't get to see you very often, but Dr. Patel was a hero. He came in and did I have a very special patient sitting here next to me who's traveled all the way from Tennessee.
Yes, sir.
With his family for one purpose, and that is to get his neck fixed.
In the wild, I've trained animals for 25 years, not jumping through fiery hoops, but just mostly behavior, come, is, just a few words. We had 52 big cats, tigers, lions, leopards, cougars, lynx. This is me about 6 years ago in the tiger cage. And this guy here, we raised him from a baby.
That's special.
I'll tell you what, the special part is being here.
And how long have you been dealing with this problem with your neck?
It's come on in the last 8 weeks strong, but after I start thinking about it, you know, even 6 months ago, I was seeing things happen that I couldn't understand why. And I just want to get back to somewhat where I was at and get the feeling back in my hands, my stability, a little strength where I can get this boy up.
Well, what's going on, as we've talked about, is you've got these herniated discs, bone spurs in your neck that are pinching down on your spinal cord and nerves. And I'm going to go in there tomorrow with a laser, and we're going to open all those spaces up, get the pressure off the spinal cord and the nerves, so you can start getting some feeling back and strength back in those arms.
That sounds great. That's why I'm here. Then I've researched, and I kept coming back to you all and seeing the testimonies and seeing, watching hour after hour after hour of the surgery. And that, you know, that says a lot if you can do it live on Facebook. It's just a pleasure to be here. I feel safe. I feel like when we arrived last night, we drove up in front of the place, and I told my crew and my wife and my driver, I said, we have arrived. We have arrived. Thank you so much.
We'll see you tomorrow morning, all right?
I appreciate it so much.
So we did surgery yesterday with the laser. Everything went really well. You can actually see the 4mm incision right there, 3 discs. He didn't want fusion, and so he found Duke Spine Institute and he came here.
After the surgery, when I talked to her, I was still a little bit drowsy. And 4 hours later, we were sitting over at a restaurant, seafood restaurant, eating seafood, and I could clap my hands at the baby because he claps when he does something good. And I could clap with him without missing my hands.
And you're already getting strength back in your arms and legs. You're getting control of your bowel and bladder back again. That's great news. It's a great sign. I think you're going to keep improving and hopefully get you back to normal.
You are the best. That's why I'm here. That is why I'm here. It is amazing. For the time I walked into this place, I felt at home. I felt like I was with friends all the way through surgery. When we walk into this surgical room, everything's so clean. I feel like I'm in a dream. I really do. Thank you so very much for what you've done.
You are welcome. And I think maybe you can hear me now. So we're just finished a procedure that we've started doing more recently. It's not that we didn't know how to do it before. I've known how to do this procedure for years. But what we're finding is that the traditional rhizotomy procedure that you may or may not know about, but it's very commonly done. It's done in all parts of the spine, whether it's this being the skull. This is the cervical part, or the neck, thoracic part of the spine, and then lumbar is the lower back down here. The most common place to do rhizotomy procedure is the lower back. And let me just show you what I'm talking about. So there's really 2 types of joints in the spine. And they both get injured. They both cause pain when they're injured. And one of those joints is the disc, okay? And the disc is big. And the disc is a cushion between the bones called vertebral bodies, whereas the back part of the spine connected to the vertebral bodies has these bones called facets. And there's actually a joint between those bones right there. I don't know if you could see it, but when I move the spine, you could see the joint moving, okay? Don't pay attention to the screws and rods, but that joint right there is a facet joint, okay? And there's a left and a right facet joint for each disc. So between 2 bones in your spine, 2 vertebrae, you have 3 joints. You have a disc, a big disc joint. You have 2 small facet joints in the back. So the patient we just treated, and many people out there have chronic back pain that comes from these facet joints. And what happens is you get into an accident where you suddenly snap the joint, and the surface of those bones is covered with cartilage. So when you smack a joint surface with cartilage, you chip off a little bit of the cartilage, and you create inflammation inside that joint. Well, that inflammation doesn't stop. It just keeps going and going and going. And a lot of times it'll just create stiffness and pain in your back or neck, for example, if it's in the neck joint. And it just, the inflammation just eats up the joint and destroys the cartilaginous surface, destroys eventually the joint capsule, which is around the joint. Long story short, people get horrible pain that comes from these facet joints. So a treatment that's been developed for many years, and it's not unique to Duke Spine, it's done all over the world, is called a radiofrequency ablation or rhizotomy. And what we're doing basically is we're taking the nerves that feed the joint and take the pain signal from the joint up to your brain so you know there's pain in your joint, and we're basically cutting those nerves. And the traditional way of doing it is by using a probe, okay, called the rhizotomy probe or radiofrequency probe. And you want to target like right here. So let's say this joint is a painful joint. You want to target just to the side of the joint, right about there, okay? That's where the nerve runs that goes to that joint. And then again, you want to target the level above because that nerve runs down here along the pars to the joint. So you got to get, if you want to treat the facet joint pain from this joint, you got to get the nerve above and the nerve at that level. And what I mean by getting is you have to burn them. And so all these doctors do radiofrequency ablations blind. They basically look at an x-ray, they put the needle, like we showed you we were doing during this procedure, and they put a probe in there and they heat it up with a machine and create plasma at about 80 degrees Celsius. So the problem is you can't see where the nerve really is, and the nerve is usually surrounded by all this soft tissue. It makes it hard for the probe to actually get the nerve. And it's kind of a, poking in there and hoping you're in the right place. So the procedure doesn't work that well, and there's a lot of people who get rhizotomy and it wears off after 3 months, 6 months. Well, in some people it wears off right away because we weren't even close to where the nerve is that we're supposed to get, called the medial branch of the dorsal ramus. Well, endoscopic surgery is new, and it allows us to actually go in here and see that nerve, and then using the laser, I just slice it right in half, and that's what we did today. So why doesn't everybody just do it? Because it's a surgery, and it takes a highly skilled surgeon who uses the endoscope, and not many surgeons know how to use the endoscope on the spine. I would say less than 1% of spine surgeons know how to do endoscopic surgery on the spine. At Duke Spine Institute, we are the world's leaders in endoscopic spine surgery. And most of my surgeries are done on a herniated disc. That's the herniated disc right in there. But today we did a procedure not on the disc, but on the facet joint behind the disc. So today, the surgery you just watched was an endoscopic transection of the nerve that goes and feeds the facet joint and takes those pain signals up to the brain. We call that the medial branch of the dorsal ramus, okay? Except down here at L5-S1, where it's not called the medial branch of the dorsal ramus, it's quite literally called the dorsal ramus. So that's what we did at L5-S1.
Alright, well, we have our first question from YouTube. We have a patient that says on May 27th, 2021, he had an unstable burst fracture of L3. The fix was an L5 to T12 fusion. When can he expect the nerve pain to go away?
Wow. I'm so sorry to hear that. So something I say over and over and over again, folks, this is so important, is figuring out where people's problem is in the spine is actually pretty easy to do now. But 99.9% of doctors that take care of spine patients with back and neck pain, they don't know how to do it. So they literally are guessing, or they just say, go to pain management, I have nothing for you. The reality is that 99% of back and neck pain can be cured as long as you can identify the source. But the problem is 99% of doctors cannot identify the source, or sources, plural. Probably 50% of the patients that come to us with chronic back pain or chronic neck pain have more than one source. It may have started out as a herniated disc that was causing their back pain, but then after they leave the herniated disc causing their back pain alone for a long time, then they get pain in their facet joints, they get pain in the SI joint, they get pain in various places. So it's really up to the diagnosing doctor to make sure that you figure out all the sources of pain. And when patients come to Duke Spine Institute, I literally check all the pain sources to see if patients have, yes, maybe disc pain, but what about facet pain? What about SI pain? What about piriformis? So we're checking all of our patients on examination to see if they have other sources of pain. Why? Because if you focus on the one thing that you see first and you're going to miss the other 2 or 3 causes of pain, then the patient can get that one thing you see first fixed and the pain goes away. However, they still have pain because you've not addressed the other sources of pain. Like I said, 50% of patients with chronic back pain have more than one source for their back pain. So fixing the one source, like a herniated disc, will not take all their pain away. If you want to get rid of people's pain and cure their pain, you've got to identify all the pain sources. You have to treat all the pain sources. This doesn't happen in 99% of doctors' offices. So you need to find the places that are really good at doing it. Duke Spine Institute is consistently good at figuring it out. The second thing you need to do after you source the pain is you need to actually do the right treatment. So this patient is saying that he had a burst fracture of L3, okay? So L3 is, if you want to count and figure it out, you look at the tailbone, that's the sacrum. The one bone above it is L5, then the next one is L4, then the next one is L3. Then the next one is L2, the next one is L1. This patient had an L3 burst fracture. There. The typical treatment for this, if you're going to do a fusion, would go from L2 to L4. L2, L pass L3 and stick screws in L4. So your screws would be in L2, skip L3, and go to L4. Sometimes you can even get screws in L3. That's a L2, 3, 4 fusion. This patient had
All the way to
T12
12.
fused all the way down to the sacrum.
To L5, yeah.
Sorry, to L5 right here. That's shocking. Nobody needs that much fusion done for a simple burst fracture of L3. So unless I'm missing something, an L3 burst fracture should have had an L2 to L4 fusion, not a T12 to L5. But what does a T12 to L5 fusion do? Well, basically the only thing good that it does is the surgeon makes a lot more money for doing a bigger surgery. But the patient has a lot more pain and suffering as a result of the surgery. You have a bunch of metal put in your spine you didn't need, and you've lost more levels of fusion. So unless I'm missing something, I'm absolutely shocked that your surgeon did a T12 to L5 fusion. It's totally unnecessary. Now, that said, it's not the worst thing in the world. He did do a couple of extra levels of fusion. If it was my back, I'd be pretty upset about it, but let's just put that aside. The question I'm being asked specifically is, what?
If it's L3, why did they start with L5?
Yeah, why do they need to go to L5? They don't. They just need to go to L4. You need to go one level above, one level below the fracture. Now, there may have been additional fractures that I'm not hearing about, in which case it's appropriate to go further down and further up. But what is the question specifically from the person?
When can I expect my nerve pain to go away?
When can I expect my nerve pain to go away? It should have gone away right after your surgery. You should have woken up without nerve pain. That's what I would expect. People who have nerve pain, it's usually from the nerves being pinched, and the surgery is supposed to unpinch the nerves. So I have to admit I'm a bit lost for words as to why you still have nerve pain. But again, it comes back to what I've said a million times. Quality of spine care across the world and United States, anywhere, is so shoddy. It's so hard to find good surgeons that do things right. And it sounds to me, unfortunately, like your nerves are still pinched based on what I'm hearing from you. And it also sounds to me like your surgeon may have done a lot of unnecessary fusing. So why does this happen? Honestly, there's just bad doctors. There's no two ways about it. Bad surgeons, bad people make bad surgeons. Bad people make bad doctors. I'm sorry. You know, I've lost confidence and faith in the medical profession myself. I was trained, you know, to be a neurosurgeon at the highest level. I've seen all kinds of doctors, worked with all kinds of doctors, and the way they treat patients now, it's shocking to me, especially since there was so much screening that was done, you know, back in the days before you go to medical school. Like, medical schools were so careful about who they admitted to medical school to make sure that the people they were bringing in to be the doctors of the future were actually good people, They were altruistic and empathetic, compassionate, and they always put the patient first. But that's not what I'm seeing anymore in medicine. I'm surrounded by thieves and villains in medicine. I'm sorry to say it, but it's absolutely true. You need to know that so you can protect yourself. What other questions are there?
The other one is, I never knew this kind of procedure existed. Thank you so much for explaining it. And the last one is, thank you so much for your time and your response. Greatly appreciated.
My pleasure. I'm Dr. Dugmajian, and Diego's here next to me. And unfortunately, Diego's going to be leaving. He's got some personal stuff going on. He's going to head back home to be with his family in New Jersey, and we're going to be out a videographer. So we may not have any broadcasting for a while. I don't know how long it's going to be, but hopefully we can get this back on the road. It depends on whether or not I can get Sonny to come to work. Right. Yeah, Sonny is at home with his family, you know, and hopefully Sonny will be back soon and be able to take over the broadcast. But we're having the same problems everybody else is in terms of getting staff to come and work. And I know it's a nationwide issue right now. But that said, hopefully we'll be back on track soon. But be patient with us. We've got one more surgery today. It's going to be a lumbar Duke laser disc repair. This patient has back pain in her lower back. And the pain actually goes on both sides, left and right, down her legs. I figured out that one disc is more to the right side, herniated. The other disc is more herniated to the left side. So I'm going to go on both sides, hopefully get rid of her back pain, get rid of her leg symptoms. As far as endoscopic facet joint denervation, which is what we just finished, yeah, we're hoping to do a lot more of these. Like I said, I was trained to do them years ago. I just don't normally do facet treatments. I leave that to Dr. Patel. But we're seeing more and more patients who have facet pain and they basically fail with the traditional rhizotomy, and so the laser endoscopic rhizotomy is a great way to do it, and it works really well. I'm going to go check on our patient shortly and see how she's doing. But we'll be back with you in about 30 minutes for the next surgery.